Good day again, and it's once again an incredible pleasure to be here and be a member of this wonderful meeting. And I'm going to finish up my participation with a talk on middle meningeal artery embolization. Once again, I'd like to extend my sincere gratitude to Dr. Wozniak and, of course, Dr. Ilyuk for this very gracious invitation. So I first wanted to start by just highlighting once again my relationship with Roman. This was during his first visit to the United States, and we were very happy to have him here as a host. And we would certainly look forward to him visiting or any of you visiting with us. And we really appreciated our time together. And looking forward to the next time, Roman. So, middle meningeal artery embolization. The first comment I have to say is, why bother? I mean, the chronic subdural hematoma, right? It's an intern case. It's a case that is just so simple. It's idiotic. It's such a bore. Stupid blood clot, et cetera, just like our alien friend has all the answers. Well, those of us who've been around the block and have a few gray hairs here realize it's not so simple, right? And things are not always as they appear, or as this owner of this cat, I would say, is rather complicated, right? Trying to make something out that it isn't. So I want to just highlight this new technology for treating subdural hematoma, because it really does indeed give us one more tool in the armamentarium for treating this devilishly, fiendishly, if I may say so, disease process. So the problem, it's a very familiar problem to all of us. Once again, one of these problems that tends to occur more as we age more. So it's a familiar problem with recurrence rates ranging anywhere from 11 to 33% after a subdural drainage procedure. And the pathophysiology is much more complex than just a simple, silly blood clot. There's an inflammatory component. There is what's been described as sinusoidal neovessels that appear in chronic subdural hematoma membranes. There's a vessel supply for the middle meningeal artery complex that now we're seeing more and more is something that is a chronic weeping or leakage of fluid, serum, etc. from this, as well as proteinaceous material. Because if you think about it at first blush, it doesn't make much sense that a patient has a mild trauma, rips, so to speak, a bridging vein. The bridging vein leaks and then tamponades, and then we take the clot out. Why should it come back? So these newer models of the pathophysiologic features of subdural hematoma try to address that and incorporate that. And I think they're much more on the right track. So middle meningeal artery embolization. Why is it attractive to us? Well, it once again is getting at this root problem of leakage of various proteinaceous materials constantly into the subdural space. Obviously, the middle meningeal artery is a great embolization target, and it seems to be associated with the majority of the typical chronic subdural hematoma anatomic locations. So when would you do, or how would you do some form of application of this as a timeline type of procedure? In other words, would you do it as a preoperative adjunct before you do a burr hole drainage or a mini craniotomy? Would you do it as a postoperative adjunct after you do burr hole drainage or mini craniotomy? Would you do it as a standalone therapy? In other words, is middle meningeal artery embolization enough to treat an individual with chronic subdural hematoma? And these are all questions that are actively being addressed. The application of middle meningeal artery embolization has been used in all of these circumstances. So when are times that you would not use middle meningeal artery embolization? Well, if there is significant severe mass effect, rapid neurologic decline, obviously you need to take care of that in a more typical fashion first to alleviate mass effect, because middle meningeal artery embolization takes weeks for it to achieve fruition, so to speak. So you're not going to see a mature response for perhaps 3, 4, 6, 8, 10, 12 weeks. So if you have a patient who is amenable to slow recovery and a brain that is able to tolerate slow improvement, this is a great application, but it is not appropriate for someone who needs urgent decompression, although it could be used as a post-op adjunct in that situation. So what's the technique? Techniques are all very similar, and I'll show you my technique and talk about some finer detail aspects. So first is to place a guide catheter into the external carotid artery, usually a 6 French guide catheter. Then a super selective catheterization needs to be done of the middle meningeal artery with a microcatheter. There are many different ways to do this, many different systems that are out there, none of which really seem to be better than the others. So it's mainly operator preference. One point about middle meningeal artery super selection, you need to go distal to the foramen spinosum segment, and that's so you can avoid any potential spillover that could affect or could lead to issues with blood supply to cranial nerves, such as the 7th nerve or the 12th nerve. Also, you want to try to be as selective as you can in placing the catheter where the brunt of the, or the bulk of the subdural hematoma is. So at least my preferred area to go is the division point between the anterior and posterior if it's a pretty large cerebral convexity. If it's more just purely anterior, then you could go with just the anterior division. So this external carotid superselective angiogram demonstrates the middle meningeal artery, and the tip of the guide catheter is just outside of the screen at the lower area. So we're seeing some very nice anatomy with the blue arrow demonstrating the middle meningeal artery target. It's very important to understand, and very important when I consent a patient, to let them know that although we're going to attempt this, we have to do a diagnostic first, and there might be anatomic issues that lead to this being not the best idea, because sometimes patients have unusual anatomy or very difficult tortuous anatomy, and not just in the middle meningeal segment or the external carotid, but I had a patient a few weeks ago that had 2 90-degree turns in their very proximal common carotid artery on the left side as it exited the aorta. And that would have meant I would have had to straighten that artery with the guide catheter, which is a maneuver that, yes, we do all the time, but it can lead to an increased risk of vessel dissection. And I didn't think it was worth it in this particular patient who had very mild symptoms and a small residual subdural to press the issue that far. So you need to be obviously exercising very good judgment. This is a super selective microcatheter angiogram of the middle meningeal artery division point. And what the arrow is showing you is the distal fiducial or marker on my microcatheter. And this is called an Apollo microcatheter that I'm using here. The Apollo is nice because it is actually a detachable microcatheter. So if you're using adhesive embolics, glue, so to speak, colloquially stated, the risk is always that the glue gets trapped in and around the microcatheter tip, and the microcatheter tip gets glued in. So this particular catheter is by design going to separate approximately 15 to 20 millimeters from the tip, and it's designed to be left behind in the vessel as an additional embolic material. But once again, you want to go as distal as possible so you can still treat. But the more distal you are, the safer it is. What type of devices can you use to embolize with? Well, silk suture goes way back. And when I was a fellow in the 1990s, we did do some cases with silk suture. It works beautifully. It is dirt cheap. Everybody has it. So how do you do it? Basically, you take silk suture, like 3/0 silk. I usually cut it about 8 to 10 millimeter segments, and then you backload the silk into the microcatheter and then just flush a bolus of saline, and that will force the silk suture into the arterial bed. Silk suture, very much like latex, is highly reactive and inflammatory. So it's excellent because of that feature. Matter of fact, our US FDA removed latex balloons from our armamentarium because of that. because of latex allergy, even though they were excellent modalities to use for treatment of carotid cavernous fistula, for instance, places where you wanted a lot of scarring and reactivity. So silk suture will certainly do that for you. And once again, it is absolutely dirt cheap to use. It just takes a little bit of time. Not so much the preparation, but you have to be patient with each bolus. And it may take 15, 20 minutes of squirting this silk before you finally get a result, but the result will work very well for you. In a similar vein, gel foam particles. You can use sterile gel foam and chop it up and use it as a particulate matter. It works very well. I often will make a slurry with contrast and gel foam if I'm going to go that route. And once again, readily available, very cheap. Polyvinyl alcohol particles, PVA. When you see particle embolization in the literature, this is typically what we're talking about now. That's plastic dust, as many of you are well aware, ground down to a certain range. So we're probably going to use 50 to 150 micron range to do this type of procedure. So you permeate pretty nicely into it. That's a similar technique to tumor embolization. And once again, I mix it, make a slurry out of it that's very thin with contrast, and then inject that repeatedly until I get the effect. Coils, detachable coils can be used, as well as Berenstein liquid coils or injectable coils, tornado coils. There's many, many typical coils out there to choose from. The only problem with coils is that they're not going to permeate. So you could put a coil at that very proximal part. Sometimes you use it as an adjunct, as an accessory type of embolization approach. And then finally, liquid embolics. Onyx 18 is the most common one that's used today, but you could also use N-butylcyanoacrylate or Trufil, as it's marketed by Cordis, or histocryl, as it was used in the past as well. And both of those have pros and cons. They're obviously the most expensive route to go. Onyx is nice because it does have that degree of pushability or permeation and a relatively long working time, but it uses DMSO as the solvent carrier. So patients who have allergies to that or other issues with that can arise. DMSO is rather obnoxious to use and can cause some pain. So you may need to pre-treat with lidocaine in that vascular bed if you're going to use DMSO. Because the patient will have potentially a lot of pain when you inject. This is what a liquid embolic onyx cast looks like. This is a patient immediately after middle meningeal artery embolization. You can see with the arrow that faint but radiodense onyx cast going through the proximal middle meningeal and then to the division point. If you used N-butylcyanoacrylate, it would look very similar to this, depending on how much tantalum you mix in. This is what an onyx cast looks like on a CT scan post-embolization. And once again, you can see I've embolized from just distal to the foramen spinosum, and then all the way on the next cut, you can see it in the groove in the bone for the middle meningeal artery. Sometimes if your radiologists aren't used to looking at this, it may puzzle them as to what they're looking at. But rest assured, this is a perfectly normal appearance of a successful embolization. I'm going to give you a case example here. This is a 42-year-old truck driver who presented to an outside institution with hearing loss. For some reason, I don't understand quite the logic path, they never imaged this patient, but they proceeded to do a lumbar puncture. The patient developed severe headache immediately after the lumbar puncture. And then subsequently developed a right hemiparesis. He persisted with this, being clumsy with his right side, staggering gait, and headache for about 2 months, and then he presented to my hospital, also with an additional component of confusion at that point in time. CT scan was done in the emergency department, and you can see that there is a mixed density subdural hematoma over the left frontal parietal convexity, chiefly causing significant mass effect and a significant shift of the brain. So as I mentioned earlier in the talk, this is not a case that I would recommend middle meningeal artery embolization as a sole standalone approach. This patient requires craniotomy to have prompt decompression and then certainly could undergo an embolization thereafter. We also did rapidly an MRI because, as I mentioned to you earlier, this patient's initial complaint was hearing loss. So I wanted to be sure you didn't have a CP angle tumor or something, but this just shows you vividly that subdural hematoma of a mixed signal with multiple ages in it. So the intervention was left frontotemporal parietal craniotomy and evacuation of subdural hematoma. There were very thick membranes. The patient did have a seizure in the postoperative period that required persistent intubation and mechanical ventilation, but thankfully the seizure was lysed very quickly with anti-epileptic drugs. His post-op day number 1 head CT is here, and you can see that we do have significant subdural hematoma, reaccumulation of an acute phase. His shift is much better, but still this is a pretty significant amount of hematoma burden in that subdural space. So I monitored the patient and he improved significantly over the course of the next few days. So he was extubated, and I plan to proceed then with a middle meningeal artery embolization to, so to speak, finish the job and to consolidate the healing. So I use polyvinyl alcohol or PVA in this situation. His headache, seizures, and hemiparesis were all gone within 6 weeks after the embolization procedure. This is his 14-week post-embolization scan. You can see there's just the tiniest little 1 to 2 millimeter remnant of the subdural hematoma. So he is back to normal at this point in time and back to work as a truck driver. So this is a nice example of using middle meningeal artery embolization as a postoperative adjunct. What are the pitfalls? What could go wrong? Kind of in the same vein as what to do if your dog eats marijuana, right? Or my favorite, in the right side of the panel, the expression on that cat's face who is being forced to swim during a flood is the exact same expression I have when I discover a complication of mine or a postoperative result that I'm not too happy with. So what could go wrong? So first off, absent middle meningeal artery. So if your patient especially has had prior neurosurgical intervention, the middle meningeal artery may have been coagulated. If there was a craniotomy done, either for subdural or for something in the past, you may not have a middle meningeal artery. You may have dural supplies from other areas, which are much more problematic, such as the anterior falcine artery coming from the ophthalmic. That would probably be a pretty tricky embolization procedure to do. So you have to, once again, be extremely careful with your judgment. Cranial nerve supply, as I mentioned, you have to be quite careful. And if you are unsure about your status of your microcatheter in terms of the anatomic location, and if the patient is being done under local anesthesia or mild sedation, you can do a lidocaine intraarterial test. I recommend between 5 to 10 milligrams of direct intraarterial instillation, followed by immediate cranial nerve exam of the relevant parts of the cranial nerve anatomy. So that's an excellent way, a provocative test to determine whether or not this patient, and indeed, is going to get into trouble if you embolize from that position. The most important, though, aspect of this slide is this third one, and that is extracranial to intracranial anastomosis. So it is absolutely critical to scrutinize the baseline external carotid artery run to be sure you don't have, for instance, a contribution to the retina and the periorbital area from the middle meningeal artery, or that you don't have peel arachnoid contributions. And this is especially pertinent, of course, in patients who have internal carotid high-grade stenosis or occlusion. And that's the very typical scenario you're going to see. These patients have done their own ECIC bypass, and you certainly don't want to disturb that by blundering in there and taking their middle meningeal artery, because you're going to give them probably a significant cerebral ischemic infarct. A few moments to end up with doing a brief literature overview. So the first case report was in the Journal of Neurosurgery by Mandai and his group in the year 2000. So this has been in use for 2 decades, believe it or not. but is really reaching a more mature state these past 2 to 3 years. So there are multiple trials underway addressing all those different timeframes of application for the middle meningeal artery embolization procedure. Jumah published in 2020 in Acta Neurochirurgia a meta-analysis, and they looked at middle meningeal artery embolization for refractory chronic subdural hematoma. They had 177 identified patients in the literature. So the complication rate was 1.7%, so probably pretty acceptable by most of our standards. Technical failure rate, meaning they tried to do it but couldn't achieve it for whatever reason, was 2.8%. Most importantly, though, if a patient underwent embolization, they had a 26% lower risk of hematoma recurrence versus a patient who was not embolized. And if a patient was embolized, the need for rescue surgery was only 2.7%. So that's a pretty compelling argument, I would say, in favor of embolization as being a useful adjunct for middle meningeal artery pathology, such as chronic subdural hematoma. Shotar just published in the Journal of Neurointerventional Surgery the use of embolization as an adjunct to burr hole drainage in either a patient who has a recurrent chronic subdural hematoma after their first burr hole, or in a patient who's deemed to have high recurrence risk. And those are patients who are chronic alcoholics or patients who are on antiplatelet or anticoagulation drugs. So they had 91 middle meningeal arteries that were embolized in a total of 89 patients. And when they looked at the need for further surgical drainage, if you were embolized, there was only a 4% of those patients who needed that. Whereas the controls, who were patients who had traditional burr hole drainage, 14% of those patients required further surgical drainage. So that was a statistically significant result at a P of 0.02. Finally, Rajah and the group from Buffalo just published in 2020 in Journal of Neurointerventional Surgery transradial approaches to MMA embolization with Onyx. So what do I mean by transradial? As you're probably aware, you can use a radial artery approach very typically in cardiology, but interventional neuroradiology, endovascular neurosurgery has also been adopting this. And the group at SUNY Buffalo, led by Nick Hopkins and Adnan Siddiqui and colleagues, are very interested in pushing the envelope of not only embolization of tumors, but also aneurysms, delivery of pipeline devices, et cetera, through the radial artery approach, as opposed to transfemoral. So this is their first series of 44 patients. So 37 of these patients had embolization as a standalone therapy, 5 had it as a therapy for recurrent chronic subdural hematoma, and 4 were planned adjunctive therapies 24 hours after a burr hole drainage. The average follow-up was 8.4 weeks. The complication rate from embolization was 2.2%, very similar to the prior study. 52.3%, so a little over half of the patients had a complete resolution of their hematoma with this technique. 34% had a partial resolution, so definite improvement in over 86% of the patients. 13.6% had minimal or no resolution, and 0% tellingly had no growth in their subdural hematoma size after embolization. So in summary, I just wanted to present with you some of our newer features of middle meningeal artery embolization, and for you to think about this as an adjunctive or even a standalone therapy for your patients with a devilishly complex and persistent problem that we've seen all of us who've been around the block deal with this, which is the chronic subdural hematoma. Once again, thank you so much. It's been a real pleasure to be part of your meeting this year, and I hope to see you in person sometime soon.